This podcast is brought to you by the Pacific Neuroscience Institute Foundation. Are you looking to support your memory and optimize your quality of life? Develop a healthy brain for brighter days at PNI's Lifestyle Program, available virtually and in person. Reserve your spot today. Visit pacificlifestyle.org to learn more.
Hello, this is Anthony Effinger. I'm the host of the Think Neuro podcast at Pacific Neuroscience Institute. And today I'm talking with Rebecca Lewis. She's an audiologist at PNI. Thanks for joining us.
Thank you for having me.
Let's start with the basics. Tell us what an audiologist does.
So as an audiologist at PNI, I am a cochlear implant audiologist. So it's a little different than maybe the traditional audiologist that you see to dispense hearing aids. I help evaluate patients for a cochlear implant if they're no longer benefiting from hearing aids, or if they have significant hearing loss in one ear and not the other. We'll get into that, I'm sure, today, but I really focus on making sure people who don't benefit from hearing aids anymore can benefit from a cochlear implant. I also diagnose babies and infants with hearing loss, and we treat them across the lifespan, getting them their hearing aids and getting them their cochlear implant if necessary. So It's a really exciting role. Yeah.
Tell us what a cochlear implant is for people who haven't encountered one of those yet.
So I can start a little bit with a hearing aid. A hearing aid amplifies sound so that you can hear better. So it's using the hearing system that you have. So it's turning up sound, and it's programmed to fit the needs of each individual. So if you have more hearing loss in the high pitches, it boosts the high pitches more than the low pitches, and so forth. But if a hearing aid doesn't provide enough access to sound, or when you turn up the sound, it's not clear, that's when you might be a cochlear implant candidate. So a cochlear implant basically bypasses the damaged hearing system and stimulates the nerve directly. So the hair cells in the cochlea are damaged, and that's what causes some hearing loss. So instead of using those hair cells to stimulate the auditory nerve, which sends a signal to the brain, we replace those cells with electrodes, and the electrodes stimulate the nerve, and that sends a signal to the brain, and that's how we hear. There's two parts of the cochlear implant. This is the part that Dr. Volker, our cochlear implant surgeon, implants. So that's the part that goes under the skin and gets threaded delicately into the cochlea. And then there's a receiver stimulator under the skin with a magnet. You can't see anything. And you can't hear anything with just the implant. You need the external part to pick up the sound, change it to a digital code, and then it sends it across the skin to the implant, which stimulates the nerve. So when you take off the outer piece, just like a hearing aid, you don't hear. And when you put it on, you can hear again. So the outer part of the cochlear implant is called the speech processor, because it processes sound, it processes music and speech, and it sends it across the skin to the cochlear implant.
Okay, you described the hair cells.
Mm-hmm.
Are those different from, I think they are, the tiny little bones that we talk about in our ear that do the amazing things?
So the auditory system has sort of three sections, if we're going to talk about it really simply. The outer part, which is your pinna that collects the sound, that sort of like captures it and funnels it into the eardrum or into the ear canal, and then it vibrates the eardrum. And then the vibration of the eardrum sets the little bones that you're referring to are the inner ear ossicles, which are the smallest bones in our body. So those are set into vibration, and then that stimulates fluid movement inside the cochlea. So those bones press on the cochlea, and when the fluid moves, it shears these hair cells in the fluid, and those cause action potentials on the auditory nerve, and that sends the signal to the brain.
Wow, that is just an incredible structure.
And it's so small, it's like the size of a dime, and it's adult size at birth, actually, not the outer ear, but the inner ear is adult size at birth. And that's why when we implant babies, they can have those cochlear implants for decades and decades and decades.
But your ear structure, that whole thing, you just most of what you just described, the inner part, is you're born with it at the size it's going to be.
Correct.
Wow, that's fascinating.
And that's part of the reason babies can hear in utero, and why they're so, you talk to your baby, you play music for your baby. because the ears are developed early on and they can hear. And yeah, the outer ear is the part that, as you can see, as someone grows, their ears grow.
Sure.
Yeah.
So that suggests, I mean, I'm just spitballing here, but that suggests to me that evolutionarily, it was very important to have hearing from early on.
Yeah.
Right. It's because it's prioritizing this large structure in a small space at birth, right?
Correct. Yeah. I mean, hearing, if we can't hear, you can't develop communication, you can't develop speech and language. You need to hear sound to understand it, obviously. So it's so important. You can't communicate unless you have a communication modality, unless you're using manual communication, which is sign language. If the goal is oral language and spoken language, then you need to be able to hear what you need to produce. So it's super important.
Okay, and so just so the cochlear implant bypasses all of this and goes straight to stimulating the nerve.
Correct. So you're no longer hearing through your ear canal. Exactly. You have microphones that sit either on top of the ear, over where the magnet is under the skin, and those collect the sound, converts it into a digital sound, which is sent across the skin. It's held in place by a magnet so that they can communicate. So there's a magnet under the skin and a magnet over the skin so the coils can align and it can send the signal to the implant.
Does sound heard through a cochlear implant sound the same as one heard through your normal, a more run-of-the-mill normal ear?
That's a great question. So, no, a cochlear implant sounds different. We always talk about we really, really dive into realistic expectations of a cochlear implant when we're talking to patients. It does sound different, especially in the beginning, but we know based on research, patients usually hear really well and are able to understand speech through a cochlear implant by 3 months, and they start to develop it starts to improve the quality of sound as well with practice. So the quality might sound more robotic and high pitched in the beginning, and then it starts to sound more and more natural. And what's really interesting is now that candidacy is expanded to single-sided deafness. So normal hearing on one ear, profound or no hearing on the other ear. It's now FDA indication to implant those patients. So those patients in research can actually compare their normal ear to their implant ear. So there's recordings online and things from different labs across the country of patients trying to express what the implant sounds like to them, because they can actually tell you the difference between normal hearing and a cochlear hearing.
When you do a single ear implant, the ears must harmonize somehow.
They do. So the cochlear implant and the acoustic hearing from the natural ear your brain can integrate those signals. And, we now know that it helps you localize sound again, because if you only have one ear, you cannot localize sound. You use microsecond timing cues between the ears to tell exactly where sound is coming from. If you have one ear, you can't localize sound. So while the cochlear implant and the natural hearing have slightly different timing cues, it's much improved compared to no hearing and hearing. So people are able to localize sound, which gives them better spatial awareness, improved quality of life, improved ability to hear in background noise, because by virtue of having two ears, you were talking about evolution before, we have two ears for a reason. It helps us discern where we're hearing, where sound is coming from. It helps you hear better in background noise because our brain compares signals from both ears. And it actually gives us this perceptual increase in loudness by hearing from two ears at the same time. So our brain uses these things from both ears. There's so many important cues that we get from hearing with two ears. And there's this listening fatigue. If you're only hearing with one ear, if you did an earplug all day, it wouldn't even really give you the entire picture, because you can still sort of hear out of that side. But if you had no hearing in one ear, it requires so much more effort to communicate, to get through your day. And there's, studies about listening fatigue. It just is more exhausting to communicate with one ear versus two.
Wow. Say that. So is this sort of, because you have two, it's sort of like, trying to think of an analogy to vision. It's not parallax exactly, but your brain is comparing two slightly different inputs, right? And saying, I'm getting this signal, it's arriving here a little bit sooner or later than to the right and the left.
I I don't think it's a perceptual difference in timing cues, honestly. Maybe if we're looking at research and we're looking at little, different degrees of localization and things like that, we might be able to better discern the timing differences. But it's nothing perceptually day to day that a patient is going to say, well, I hear the sound coming from this side rather than that side. Once they're comfortable with their cochlear implant, they should be able to not really notice too much of a difference. But I love that you compared it to the vision, because I always say that to patients, you would do something about one eye if you lost an eye. But people tend to say, oh, well, I still have one ear. And, it's important to have two.
Right. For all the reasons you just described.
Correct.
The hearing fatigue thing sounds terrible.
Right. And that's true of anyone with any kind of hearing impairment. So even a mild hearing loss is known to, increase listening fatigue if it's not treated with hearing aids. Any sort of hearing loss, patients have to put in extra effort to fill in the gaps that they're missing, or to just focus on what they're hearing, especially if there's distortion to their hearing, meaning it's harder to understand speech. So, there's a lot of factors that go into that. And I think, another factor that people don't think a lot about is the increase in, lack of awareness of where your body is in space, which can contribute to falls. And, so people with hearing loss have 3 times the risk of falls, and with increasing hearing loss, that increases that risk.
Three times the risk?
Yeah.
Okay. And that's got to be especially true, in the elderly.
Oh, yeah. And there's other compounding factors for, if there's comorbid conditions, of course. But
yeah, falls aren't falls like the number one, one of the highest risk things for elderly people.
An important part of healthy aging is making sure that you can hear, not only to improve communication, but also to reduce your risk of falls. Because patients with significant hearing loss, there's a 3-time more likelihood chance that you could risk falls with hearing loss. And it's due to, vestibular hair cell loss. So the inner ear is connected to the balance system, and that can affect your balance and your risk of falls. And also spatial awareness, understanding where you are, that's impacted by your hearing.
Yeah.
All of that can affect
That's so funny. It's not funny, but my mother, in her 90s, her hearing began to go and her falls increased.
Right.
And this was her greatest hazard, really. This was the thing they were most worried about, of course, were falls. So it makes sense, because the hearing and balance are so intertwined. So who's eligible for a cochlear implant? When does that become the solution?
So when there's a few different ways to look at it, Candidacy has expanded tremendously over the last 10 to 20 years. So it used to be you had to have almost no usable hearing, essentially deaf, to get a cochlear implant. And I think that's somehow still what people think of, but it's so not true anymore. Now it's basically, if you have a friend or a family member who feels like they've tried a few sets of hearing aids and they're not getting benefit, they should just get an evaluation and see if there's something better for them. So patients who have significant hearing loss or moderate to severe hearing loss, moderate to profound, and have poor speech understanding with a good fit, well-fit hearing aid. So if the hearing aid's appropriately fit and they're still not able to understand language and they're still not able to communicate, they should absolutely be considered for a cochlear implant. Asymmetric hearing loss, having really poor hearing in one ear, hearing loss or perfect hearing like we discussed in the other ear, those patients are a candidate as well for all the aforementioned reasons that we just discussed. Patients can wear a hearing aid in one ear and a cochlear implant in the other, and they're called bimodal because you're hearing with 2 modes. We can even implant patients who have normal low pitch hearing or really good low pitch hearing where it steeply drops off in the high pitches, which we know those high frequencies house a lot of consonant sounds that help us understand speech language. So if all you hear are the vowel sounds, someone's talking, but you can't understand them. I feel like that's a common complaint I hear from patients is I hear them talking. I can hear just fine, but I don't understand what they're saying. And that's because certain parts of speech are not audible. So Dr. Volker is a pro at this, actually. She can very gently implant the electrode array to preserve the natural hair cells in the low pitches And basically in the same ear, they end up having a hearing aid and the cochlear implant. So it's called basically electroacoustic stimulation of one ear. So we can actually use the bass tones that are natural to them combined with the electrical high pitch hearing. And we know that that helps with speech understanding. People enjoy music a little bit more because they've got that natural bass tone and quality to it. And, it's really, so there's so many different candidacy criterias, and to not bog people down with the nitty gritty of percentages and numbers on the tests that audiologists do, I usually just tell family members or providers if somebody is not benefiting from their hearing aids, if they're struggling more and more on the telephone, if they have any kind of asymmetric hearing where one ear they're not benefiting from the hearing aid, they should come in for an evaluation. It doesn't hurt to get an evaluation. It doesn't mean that we're throwing you into surgery the next day. It just means that we can explore all the options, and then we can make, an informed decision together. Cochlear implants are a team decision. We have a cochlear implant team at PNI, and we meet every single week at 7 a.m. and we talk about every single patient that we treat, so we can get truly a multidisciplinary approach to care. We even have our brain health division that's on board with us on those meetings. So if we have any cognitive concerns about a patient, we can collaborate with them. And I should add that cognitive decline should absolutely not be a contraindication for a cochlear implant. In fact, we've seen that wearing hearing aids and cochlear implants can help improve cognition or, slow down, dementia or cognitive decline, if not reverse it. There are a few studies that show, even just with imaging studies, that there are true neurocognitive benefits to hearing again, which totally makes sense. But now we have
absolutely. It's such an important input, right? I mean,
yeah. And if you can't hear, you give up in conversations. We all have family members who, they might ask you to repeat yourself once, and then they just give up, and they don't just want to, they don't want to bother with it, and that just increases their isolation. Absolutely. And that we know that increased isolation is correlated with cognition and cognitive decline and dementia and things like that. So it's sort of like all this self-fulfilling prophecy. Treating health or treating your hearing is part of your overall health.
And now a message from our sponsor. The Think Neuro podcast is brought to you by Pacific Neuroscience Institute Foundation, a nonprofit 501c3 organization. If you're inspired by what you hear and wish to support our mission of education through innovation, please visit pacificneuro.org/foundation. Has this technology been like other technologies and become cheaper and better and smaller over time?
Yeah, I don't know if I would say cheaper, but insurance covers it. So hearing aids are usually not covered by insurance for, definitely not for Medicare. Some insurance companies cover part of hearing aids. But for cochlear implants, they're mostly covered by insurance, if not entirely covered by insurance. So it's a benefit of your insurance. And still, we only have penetration rate in the market of 5 to 7%, meaning 5 to 7% of patients who could benefit from a cochlear implant actually get one. And I think it's just access, and it's knowledge. It's doing things like this. So thank you to get the word out and make people or help people understand that there's more options available to them that they might not have been aware of before. That it's an outpatient surgery. It's a very low risk surgery.
Meaning you go in one day. How long is it?
The same day. Yeah, you might come in, let's say your surgery is scheduled first thing in the morning. You might come in an hour or two before for pre-op. The surgery's, an hour to 2 hours long, and you go home, by lunch. So in the recovery time, it's very, very short. It's very minimal. People go back to work the next week, It's not like you're out for a very long time. So all of this information, we need to do a better job at getting the public to understand. Also, I think we screen for so many things in primary care visits. We definitely screen vision and all, but oftentimes hearing gets overlooked until there's a problem. It's sort of this hidden disability. So, there have been studies done where they've surveyed primary care doctors, and less than half ask, like the hearing screening is really like, how are you hearing? And it's not go get a hearing test, or, the old school hearing test was rubbing your fingers next to their ears and they could see your finger, So it's getting screenings and more screenings out there. We have an initiative at PNI working on that as well, getting hearing screenings into primary care offices. Even some of the audiologists that are amazing in our community that have been doing this a long time, but primarily work with patients with hearing aids, some of them, they just need some support, and we need to work together on making sure that their patients and these audiologists know when patients are cochlear implant candidates. So that's another initiative that we have. We're working with community audiologists. These are the audiologists that these patients have been seeing for so long. They trust them, they do a great job. So we're trying to find ways to collaborate with the community audiologists. In fact, we invite them to our cochlear implant team meetings to discuss their cases and support them in terms of when to refer patients, keeping their patient. We just work together to improve access. So we have a few different initiatives to try to combat this 5 to 7% issue of, the penetration of cochlear implants. In a city like Los Angeles, the whole city only does around 300 a year, which is crazy because we're 12 million people. 300 people get a cochlear implant in Los Angeles a year.
It sounds like when something goes wrong with people's vision,
they run.
It's all hands on deck.
Yeah.
But when something's going on with hearing, it's not so much.
Yeah, I think it creeps up on you. You're like, oh, it's a little bit of a problem, but I'll put it off. Most of the time, hearing loss is gradual.
Yeah.
Patients do run when it's a sudden drop in hearing. We usually see those patients pretty quickly. If they all of a sudden have normal hearing, it drops, or they have significant hearing loss and it drops to nothing. We'll see if there's a sudden change, but most individuals have a progressive hearing loss that's gradual over time. And, we just need to monitor those patients at least once a year, if not twice a year, if they're close to candidacy, to make sure that they know all their options. And that we look at more than just the hearing test. We look at their quality of life. What is their day-to-day, what are their day-to-day experiences? We always talk about their goals. What do they hope to do? Like, are they avoiding certain situations because of their hearing? These are all good questions to ask, because, it's not just a piece of paper with a hearing test on it where you're looking at their levels. It's a person attached to the ears, right? So we want to make sure that we're treating the whole person holistically. We're looking at their cognition. With kids, we're looking at their language skills. When I work with kids, it's definitely all hands on deck, because we're working with their teachers and their speech therapists and their ABT therapists, and the parents. Obviously, they play the biggest role. So, when I hear that kids aren't doing well, even when they have cochlear implants, we all talk about ways that we can improve their access, and maybe there's ways I can program the cochlear implant better to improve their access as well. So it's all about a team approach when it comes to hearing.
Did you said, what's the age, at what month of life can you now do cochlear implants?
FDA approval rate is now 9 months and older to get a cochlear implant. That's FDA approved. We use lots of medications and different treatments off label, which is, not necessarily based on the FDA approval. So we know, based on studies in other countries where it's approved at younger ages, that obviously having earlier access to sound is optimal, because you don't have as much catch up, right? If you wait till they're 2 years old, like back in the day when cochlear implants were first approved, there's a lot of space. There's a huge language gap. There's a big auditory access gap that they have to catch up those 2 years. But if we implant children earlier, they catch up so quickly because they haven't missed out on all of those language opportunities for very long. So we've actually done cochlear implants at PNI on 4 babies at 5 months old. And so it takes a few weeks for them to heal. And then they see me to turn on their implant for the first time at around 6 months old.
Wow.
So they're hearing at 6 months, which is fabulous. And these kids are all meeting their language, or their listening milestones at this.
How do you figure out at 6 months or younger that an infant has a hearing issue?
Well, thank God for newborn hearing screenings that are mandated now. So babies all get screened for hearing when they're born. If
Okay.
they don't pass their hearing screening in the hospital when they're born, they get sent for a diagnostic evaluation by an audiologist. So a diagnostic evaluation is basically, it's called an auditory brainstem response test, and it's evoked potentials. They need to be sleeping, and they have earphones in their ears, and we use electrodes on their head to measure the brain's response to sound. So we'll measure different pitches that are important for language development and increase the sound till we see the brain response to sound. So we can even program hearing aids based on those responses.
Wow. So this is okay. So what's the test that comes before that? That sounds like that's what you do when you know there's a problem or you suspect that
Right.
there's a
Well,
problem.
the newborn hearing, yeah.
What is a newborn hearing? I can't remember from when my kids were born. What do you do?
Yeah, the newborn hearing screening is an ABR. They put little sticker electrodes on these little cups. I don't know if you remember the cups that went over their ears.
No.
Oh, they do. They put cups on their ears. They play like a click at a low level. And if they don't see, basically it's a screener version of an ABR, so the nurse can just do it quickly. And if it's pass or fail. If they fail, they do it again. If they fail again, they get a more of a comprehensive hearing screening.
Fascinating.
Yeah.
You're actually measuring brain activity in response to sound.
Yeah, we're measuring the nerve's response to sound at different pitches and different levels, so we can determine if we needed to program a hearing aid, conservatively, how to program the hearing aid. And even with cochlear implant candidates, we start with them with hearing aids. So we try to get hearing aids on as soon as possible, as early as possible. And then they try the hearing aids for a while. We test them with hearing aids on. And then if they're not getting benefit, we move forward with cochlear implant.
Okay.
Yeah.
So what's the percentage in P&I's practice between doing infants and older people? Right.
Well, we're doing a lot more adults right now than kids for a few reasons. Right now, in Los Angeles, the demographics, we are working on providing Medi-Cal services for kids. We're still in progress. It's a long progress with a lot of red tape to get there. Dr. Volker and I have always worked with Medi-Cal for Kids, which is called California Children's Services, CCS. 80% of the children in Los Angeles that have hearing loss have that insurance.
Okay.
Have CCS, and we can't take it yet. We're both providers under CCS, but our site is not approved yet. So we're working on it. And hopefully we'll be able to provide those services soon for that insurance. But for now, we're seeing mostly adults because I think once we are approved, I think the floodgates will open. We'll be seeing a lot more kids.
That's fantastic.
Yeah.
So on the demand from adults, you've got this vast group of people out there who are not being treated, who could be. Do they exist because baby boomers, Gen X, people like me are getting older, and there's just a bigger population, or is it that we all abused our hearing by going to really loud Pink Floyd concerts in high school? Are we abusing our hearing any more than previous generations?
Oh my goodness, I have so much to say about what you just said. Okay, so first of all, there's more candidates than ever before because what we talked about earlier, candidacy has expanded. So now it's not just for super deaf people, right? It's not just for last resort, I hear nothing, you're okay, good, you can get a cochlear implant now. Now we talked about all the different types of patients that can benefit from a cochlear implant. So expanded candidacy means there's more people that it's available to that are not getting it. So that's one. The other issue that you just mentioned is exposure to sound and loud sound and conserving your hearing as you get older and using healthy hearing habits. So yeah, we're doing much poorer of a job at that than I think we have historically because we're all wearing our AirPods around town. We're streaming, we're listening to music, we're connected more than ever before. We're seeing increased rates of noise-induced hearing loss even in teenagers and younger kids. So, there's simple ways to protect your hearing. If you have an iPhone, I'm more familiar with Apple for some reason because I don't know, I have one. Sure. But in your settings, you can actually set your headphone limits. And I wish it was just defaulted this, but I turn mine on, so it limits my ability to turn up my music any louder than I set.
That's great. Yeah, and that's
you go
in settings.
Outside, you turn it up, and it doesn't go up anymore. You're like, oh, I'm at the set limit that I gave myself so that I don't give myself hearing loss. Yeah, it's in sound and haptics. It's called headphone safety.
Oh, good. Okay.
Yeah,
All
so
right.
it's in there. And then with kids, I tell families to look for noise limiting headphones. There's a great hearing protection headphone earmuff called baby bands if you're going to like sporting events with really young kids
Yeah.
to protect their ears. Musician plugs are great because it keeps the fidelity of music nice. It just turns it down instead of it being muffled by like a foam earplug. So there's
Yes.
lots of different ways to and tricks to protect your hearing, but definitely we're seeing increased rates of noise-induced hearing loss.
Yeah. I tell you what, I mean, we didn't know about this stuff,
No,
right? Or maybe that's my excuse. I don't know. But you said musician plugs. Those are, so people who are going to concerts, you often see people, I always try to remember them, but just regular old foam earplugs. But these musician plugs would be good for somebody in the audience even, right? You're saying?
yeah, they're more
Yeah.
expensive. I mean, if I go to a concert, I use foam plugs because I don't go to that many and I'm not a musician myself, but
Okay.
musician plugs are custom ear molds that have filters in them. So you can decide how much you want to turn down the sound by which filter you put in. And it basically is like a stereo. You're just turning everything down, but everything's coming in cleanly and clearly. So musicians use them a lot. They use them for monitors, things like that.
It's a great option.
The other thing I was going to mention are sound level meter apps. They're free. You can download a sound level meter app on your phone and you can.
I have one.
Great. So
I do.
Can do math and you can decide, if it's 100 decibels, that's like not safe for even a minute. It can cause damage to your ears for later. So you can decide how strong of hearing protection you need to turn it down to like a safe level.
Yeah. There was a piece in the New Yorker maybe a year ago about the health risks of noise in our lives, in cities, wherever. And it's fast. You probably know some of this, but like excessive noise, persistent noise, loud noise leads to all of these terrible things that are totally, you would think are not related to hearing. And I can't recall what they are, but I want to say they're things like diabetes. I mean, systemic things that come from like just the loudness of our society, right?
Right. I think stress and it just increases, certain levels in our blood, blood flow to the ear is an issue. So patients with diabetes are at higher risk for hearing loss, actually. So there's all these correlations, hypertension, hearing loss is the third largest chronic condition in older adults. So it just needs,
I mean, look, I shouldn't be surprised. I shouldn't be surprised.
I mean, most patients over 75 have some degree of hearing loss and probably, just at least one other health condition that they're monitoring. So we just need to do a better job at screening, maybe earlier screening, even starting at 60 or 55, so that it's not like a surprise when you're older and then it takes longer to accept it. And if we start screening earlier, then perhaps the acceptance is when we need it and when we start wearing hearing aids or cochlear implants.
Yeah.
I hope that, because we're all wearing AirPods and things like that in our ears, that the stigma of wearing these hearing devices is going down. The technology has come such a long way. It's pretty amazing. I think, I've been doing this for 15 years. And when I started, basically you put them on and they made you hear better. And that was great. Now, cochlear implants, you can swim with them on. They're waterproof. So kids can get swim lessons and there's remote microphone technology. So a teacher's voice can go directly into the cochlear implant or the hearing aids. They're all Bluetooth compatible. So you can stream music, phone calls, meetings, anything you want through your hearing aids or your cochlear implants. So you're not missing out on anything someone with normal hearing gets to do.
We talked about that with Dr. Volker. That's amazing.
Yeah.
Well, I got to tell you, to your point here, I have a couple friends who are in their early 50s who have hearing aids.
Yeah.
And they're like, look, there's no issue. They don't, there's no any shame or any, they're not self-conscious. They're like, I wanted to hear better.
Good.
And they're great. You can't, you can't see them and they're more, they're in the conversation more. So, well, listen, you have to keep up this work.
Oh, thank you.
Keep going.
You will.
I just can't. I mean, when there's a solution out there and people aren't taking advantage of it, it's like, come on.
I know, and it's covered by insurance.
And it's covered by insurance. Let's say that one more time, there's not a lot these days, right?
Right. Cochlear implants are covered by insurance and underutilized. Isn't that sad? Yeah. I know.
That'll be the title of this podcast.
Oh, no.
No. Rebecca, it's really fun to talk about this. The science is amazing, and the fact that we have such a great solution here. The hard part's done. Now we just got to get people in there.
Totally. Thank you for your time and
of course.
Curiosity about this. It's great.
Let's do it again. Thanks for joining us.
My pleasure.